It's my pleasure to introduce our Donald Olson Memorial Visiting Lecture speaker for today. Dr. Bob Centor went to medical school and did his residency at the Medical College of Virginia, where he stayed to do chief residency. He worked in the Division of General Internal Medicine there until 1993. He was first residency program director and then division chief. He moved to University of Alabama back in 1993 and started the Division of Internal Medicine and also served as Associate Dean for Primary Care. From 2004 to 2017, he has been the Regional Dean for the Huntsville campus. He served in many societies and leadership positions, including the President of the Society for Medical Decision Making, the Association of Chiefs in General Internal Medicine, the Society of General Internal Medicine, and Chair of the Board of Regents for the ACP. His primary research interest has focused on adult pharyngitis, creating a score that carries his name, and his passion really is in clinical education, focusing on clinical reasoning and thought processes in internal medicine. He's co-authored several clinical reasoning vignettes in the New England Journal, JGIM, and the American Journal of Medical Science, and he has won multiple teaching awards at UAB. He is going to be speaking to us about learning to think like a clinician. Thank you, Dr. Centor, for joining us today.
Good morning, everyone. It's a great pleasure to be here. I understand it's going to stop raining as soon as I leave town. So this is a patient that I saw at the Birmingham VA in December, and I'll read it. Okay, you might be able to see it now, and I'll tell you the story. And this is a story where the patient gets admitted to the ICU and the diagnosis doesn't become clear for about 4 or 5 days. It's a 55-year-old man who's brought to the emergency department for confusion. His wife says that he became progressively confused over the past 2 days. In the emergency department, they knew he was diabetic. They measured his blood sugar, it was 800. He had no acidosis, had a normal anion gap, and he's admitted to the ICU for non-ketotic hyperosmolar coma. This was the first time he'd been to the Birmingham VA. We had records from the California VA where he'd been previously treated, and that's one of the great things about the VA system is if somebody comes from a different part of the country, you can just bring it right up on your computer, the way all computer records should work. And he had documented type 2 diabetes. According to the primary care notes, he had been prescribed 24 units of long-acting insulin and 5 units of short-acting insulin with each meal. He told the ICU physicians that he actually only took 12 units and he only took the morning short-acting dose. In the ICU, he had a positive drug screen for cocaine. I know most of y'all have never seen that before. But that happens occasionally in Alabama. His blood glucose decreased very rapidly with insulin. He had 2 episodes of hypoglycemia in the ICU, and his hemoglobin A1C was 14. He's then transferred to the floor, and as they say, it's better to give than to receive, and I was on the receiving end. So we're going to talk first about problem representation in illness scripts. How many people are familiar with that concept? Okay, so if you're interested in education, I highly recommend reading Judy Bowen, and many of you may know Judy Bowen at Oregon Health Sciences, who wrote this great article in New England Journal in 2006, and these slides are available to anybody who wants them, called Educational Strategies to Promote Clinical Diagnostic Reasoning. It's a wonderful, wonderful article, and she talks about problem representation. It's something that you probably have done, but you didn't have a name for it. And it is a one-sentence summary of what the case really is. So in this example, this is a 55-year-old man, cocaine positive, poor diabetes control, poorly adherent, admitted with hyperosmolar state. So now you have a picture. If that's all I told you about, you'd have an idea. You've seen this guy. What are the implications of that problem representation? So if we summarize a patient in one sentence, it implies a lot of things to us. several factors might influence our thought process. He has a diagnosis of type 2 diabetes mellitus. He doesn't adhere to the recommended treatment. He's treating himself on his own. He uses illegal substances. That frames the way we think about him. We have several potential reasons for him to have a markedly elevated blood sugar. So on discharge from the ICU to the floor, we have a new problem representation. A 55-year-old man with brittle diabetes, because he had 2 episodes of hypoglycemia, cocaine positive. The brittle diabetes raised some interesting questions in our mind when we first received the patient, when we first heard about the patient before we actually had examined him. We wonder, why do we have a patient with type 2 diabetes on insulin and no oral agents? This is not very usual. Why does he so easily develop hypoglycemia? And we look at his old VA records, and it's well documented in California that he's had multiple episodes of hypoglycemia. Again, that doesn't make sense in my experience of type 2 diabetes. We go to the bedside, and he has a BMI of 13. That is not a typo. That is what his BMI really was. He had diabetes for 6 years. He thinks he took metformin at one time and thinks it didn't do any good. And he had no evidence of infection or coronary artery disease, so he didn't have any reason for his sugar to have gone up other than perhaps the cocaine and not taking his insulin. So now we have a new problem representation. So notice that we started out, we're redefining the guy as we get more information. So now it's a very thin man with brittle type 2 diabetes for 6 years. And the very thin man raised a lot of questions. We left the room, and I said, this doesn't make sense. How many people remember the television show Columbo? Good. It's really nice to have a mature audience. And for those of you who are too young to remember Columbo, Peter Falk would go into the room. He'd be interviewing the criminal, who was always a very high-class criminal, usually a doctor, a lawyer, a businessman, or a woman. And it was like he was done. He's going out of the room. He's got this schlubby raincoat on, and he turns around, and he scratches his head and says, there's something bothering me. That concept of there's something bothering me, and he did it for acting purposes, but that's true in medicine. This didn't make sense to me. So we try to match this problem representation against our illness script of type 2 diabetes, but too many features don't fit. So we have to decide that we have to consider other possibilities to explain his diabetes and his clinical course. So an illness script. So I've given you the problem representation concept. Now the illness script is what you expect to see, what the textbook would tell you or your experience tells you. So for example, community-acquired pneumonia. How many people have seen someone admitted for community-acquired pneumonia who had something else? If anybody who didn't raise their hand has never taken care of admission of community-acquired pneumonia, because it's like 40% of the patients admitted with community-acquired pneumonia have something else. And that's another long story. They usually have a short duration of symptoms, a productive cough, fever, sweats, and or rigors, an abnormal chest exam of some kind, and some kind of compatible chest x-ray. Having one of these does not make a diagnosis of community-acquired pneumonia. If radiology says there's pneumonia on chest x-ray, that doesn't mean it's community-acquired pneumonia. That just means there's an infiltrate on chest x-ray, if they don't have these other things. So this is my illness script for type 2 diabetes. This is not out of a textbook. This is just what I thought of when I was making this slide. They're usually overweight or obese. If you look at studies of type 2 diabetes, and the studies that I'm most familiar with are the studies where they gave ACE inhibitors or ARBs to diabetics with proteinuria to try to prevent progression of kidney disease, and it actually did. If you look at table 1, the mean weight is always 30, a BMI of 30. In every one of those studies, it's a BMI of 30. 13 doesn't make any sense. It's usually controlled with oral agents at 6 years. I've seen very few patients who needed insulin with true type 2 diabetes at 6 years, and they rarely get hypoglycemia because they have insulin resistance. So something was fishy here. Because he had brittle diabetes, he could have had LADA. If you've heard of LADA, that's latent autoimmune diabetes of adults. It's really like type 1. But they develop ketoacidosis because they have a total lack of insulin. And yet, with a blood sugar of 800, he had no ketoacidosis, so that made that diagnosis less possible. With a low BMI, I'm sitting there, my resident and I are talking for about 10 minutes. I says, you know, it's not a very common cause of diabetes, but could he have pancreatic diabetes? So the resident, who I'd worked with since he was a third-year medical student, goes back and talks to the patient. This is not documented in his chart. He had 2 or more episodes of acute pancreatitis before he entered the VA system. He'd had a partial pancreatectomy by his history at a private hospital, and he described steatorrhea for the past 6 years. So now we have a very thin man with brittle diabetes for 6 years, starting after partial pancreatectomy, who also had steatorrhea. And now we also understand why he doesn't take the insulin as prescribed, because he was getting hypoglycemic when he took the 24 units or when he took the afternoon glucose. He was actually protecting himself from hypoglycemia because he had no protection from hypoglycemia, because remember, pancreatic diabetes, you don't have glucagon. So our revised diagnosis is pancreatic diabetes secondary to partial pancreatectomy with both exocrine and endocrine deficiency. That complicates his treatment, gives us a new avenue to try pancreatic enzymes. Maybe we could help him gain some weight. He said he only used the cocaine the one time. Do you really believe that? But he said he was going to go in the straight and narrow. We haven't seen him back yet. I keep on checking to see if he ever comes back. So why did I call this learning how to think like a clinician? How many people have heard of Philip Tumilty? So Philip Tumilty, for those a couple of people who have known him, and actually when I gave this talk yesterday, there was somebody who had actually gone to Hopkins and rounded with Tumilty and was so excited that I mentioned Philip Tumilty. He was the well thought of superb clinician at Hopkins who taught medical students, and he was in charge of the introduction to clinical medicine course there. He wrote a book that I read in the 70s when I was a resident called The Effective Clinician, which was, it was my favorite book because he talked about what it took to be a good clinician, and he used the term clinician as the greatest compliment you could give a physician, is they were a clinician. That was how he thought of it. He wrote you can't find the book now. You can go on eBay and pay a lot of money for the book. You really probably don't want to do it, or Amazon, because it's out of print. But this is free. In the New England Journal of Medicine in 1970, he wrote an essay called "What is a Clinician? What does he do?" I apologize to the women. That was proper English in 1970. Okay, I can't help that. He would write it differently now. This was the talk he gave to the second-year students who were entering Introduction to Clinical Medicine. It's a beautifully written essay about clinicians sit down, they talk to the patient, they take a careful history, they do a good exam, and they take their time, things that we wish we could do. A couple of books really influenced me a lot. 2 books by Malcolm Gladwell. These are what I call the Reader's Digest version of this talk. Outliers and Blink. If you're going to be on an airplane for about an hour, you can read them. Many people have read Jerome Groopman's book, How Doctors Think. That's a little bit more, goes a little bit more into the cognitive science. If you want to get really nerdy like me, this wonderful book that was on the bestseller list by Daniel Kahneman, Thinking Fast and Slow, is sort of the history of the cognitive psychology of making decisions and why we make mistakes. Daniel Kahneman is the only psychologist to ever win the Nobel Prize. He did his work with a colleague, Amos Tversky, who unfortunately died prematurely in his 50s of an ocular melanoma. And the book is both about the science and it's sort of an homage to his research partner, Amos Tversky. I have to acknowledge some people. Analia Castigliani was a junior faculty member at UAB who's now at Central Florida. Brita Roy was a resident and chief resident. She's now on the faculty at Yale. And many other colleagues who did our war research, and that is not Department of Defense research, but ward attending round research. We did a lot of studies of what makes ward attending rounds successful, and they did the hard work, and I got to be a senior author. The clinical problem-solving team, one of the things we started doing at UAB 20 years ago, we were so impressed with the New England Journal of Medicine clinical problem-solving series, we decided to make that a regular conference. And we have one attending present 3 cases to another attending, so you have the presenter and the hot seat. And the person in the hot seat thinks out loud and tries to solve the diagnostic problem. It is the house staff's favorite conference because they love to see the attendings on the hot seat. And many attendings enjoy it, and some attendings are really good about never volunteering to do it. We have to thank Grubman, Kahneman, and Gladwell for their books. A guy named Klein, who I'll mention later on, this is what they call in television a teaser. Stay tuned, I'll tell you who Klein is. And the Society to Improve Diagnosis in Medicine. This is the group that's really championed that diagnostic errors are the big quality problem in medicine that we don't measure. One of the main people in that society just called the diagnostic error the base of the iceberg of quality, because you can't possibly treat the patient right if you make the wrong diagnosis. Why am I talking about clinical reasoning today? Many of you remember Jerome Cassira was the editor of the New England Journal after he left on because of his principles and the New England Journal of Medicine's lack of principles. He wrote this wonderful essay in academic medicine called Teaching Clinical Reasoning. He actually started the clinical problem solving at Tufts. He was a nephrologist, very nice man, and he argues in this article that the basic science of being a good clinician is the cognitive psychology of diagnosis. And so therefore we should be teaching it to our medical students all 4 years, our residents all 3 years, and to ourselves to understand why we make mistakes or how to become an expert. Our research, we were really surprised by this, and we were delighted with the result. The most important factor of successful attending rounds was the value of attending physicians sharing their thought process. It trumped donuts. It trumped being nice. Learners want to know, they don't want to know facts, they want to know how you use the facts. They want to know how you got to that point. And hopefully we'll demonstrate that. Hopefully that first case demonstrated a little bit. And the reason is diagnosis is job one. If we don't make the right diagnosis, our chance of helping the patient is really hampered a great deal. And it requires thinking, it's difficult, it's time consuming, and critically important. So the objectives of this talk, and I have no conflicts of interest for this talk, is to understand problem representation illness scripts. We've already gone over that. We're going to go over it one more time. Understand some reasons for diagnostic errors, and develop a process for developing expertise. So this is a great example of a patient who's admitted to my service, and I was so proud of the house staff. It was a 56-year-old man admitted with 4 days of progressive dyspnea. He had a minimal cough and a couple of episodes of clear pink tinged sputum. He denied fevers, rigors. He's felt chilly. When was the last time you asked a patient if they had chills and they said, well, I felt chilly? I felt chilly this morning when I went outside. Probably all of you did too, because it was chilly outside. But he did not have chills, he did not have rigors. And I make a big teaching point to the students and residents, don't tell me chills, did they have rigors or not? no upper respiratory tract symptoms, routine labs are unremarkable, and this is his chest x-ray. So you can try to make the diagnosis from the chest x-ray, and then I'll tell you what actually happened. Okay, everybody's got that chest x-ray. The emergency department presented this to the team as a 56-year-old man with progressive dyspnea and a left upper lobe infiltrate. The internal medicine team said, 50-year-old man with progressive dyspnea, but no purulent sputum, no fever, and no rigors. Now, the team knew that I have this obsession with the diagnosis of community-acquired pneumonia, and you better not assume that the emergency department is correct when they say we're admitting somebody with community-acquired pneumonia, or else I'll probably go berserk. So the admission diagnosis was community-acquired pneumonia, and the patient got levofloxacin. The house staff was skeptical. So the house staff said, you know, it doesn't feel like pneumonia. They ordered pro-BNP, which is 900. Not really an outstandingly high pro-BNP, but not normal. So they ordered an echo. So the patient's admitted on Saturday, all this gets done on Sunday, and I come in on to service Monday morning. His ejection fraction, we find out while we're on rounds, is 30%. He has increased pulmonary artery pressure. He then goes to cath, has a left ventricular ejection fraction of 20%. The echo's not always exactly right. He has mild CAD, so it's really a dilated cardiomyopathy, and he has a high wedge pressure. And many of you looked at that chest x-ray and thought pulmonary edema, but radiology said that he had left upper lobe pneumonia, and the ER said, okay, and they gave him levofloxacin, which really didn't help his pulmonary edema at all. When I saw him 36 hours later and took a careful history, he told us he had progressive dyspnea for 2 months, first with regular exertion, then with minimal exertion, and finally at rest. He had a history of untreated hypertension. He knew he had hypertension and just wasn't getting treated for it. And he had the loudest summation gallop I've ever heard in my career. Every single medical student could recognize the summation gallop. That's how loud it was. So why did the ER make this diagnostic error? Well, incomplete data collection. The ER, it's a very busy ER, and they're rushing through patients, and they don't sit down and carefully take the history. They get a few sentences, then they get a chest x-ray before they've really examined the patient. The radiologist said it was an infiltrate and didn't notice the cardiomegaly and didn't notice that it actually looks like pulmonary edema. Why? Because the radiologist is reading too many films, and they're not taking enough time carefully looking at it. And probably the ER said shortness of breath, rule out pneumonia, and so they ruled in pneumonia. So both the emergency department and the radiology led to this diagnostic error. And inadequate physical exam skills. You wonder whether or not anybody even listened to the chest. It was such an obvious gallop that you really didn't have to try to hear it. And then, fortunately, my house staff team did not have diagnostic inertia, but you all have seen cases where someone gets admitted with a labeled diagnosis from the emergency department, gets treated for that, and 3 days later, finally somebody says, you know, maybe it's not that. Once a label is put on, it's dangerous. Now, why does the emergency department put labels on? Because they have to, because the administrators said they have to, because the insurance companies say you have to have a diagnosis to admit somebody. At least many insurance companies do. Otherwise, you can't admit them. Why are you admitting them? Because they're sick. What are they sick with? Well, you don't know yet, and at least back in the 70s when I was a resident, you didn't have a diagnosis. You just got admitted for shortness of breath, and then they let the floor figure it out. But now they have to put a label, and that label, I would argue, in and of itself is dangerous because it might shut down thinking. So how do you avoid such errors? Well, I'm very proud of the house staff. They were skeptical. Just like my resident and I were skeptical with the diabetes patient. Just because a patient has a label, don't believe it. I don't believe what the emergency department says. I don't believe what the primary care physician says. I don't believe what the ICU says. I don't believe what I say. I reassess each day as if I don't know the diagnosis. And I ask myself if the problem representation fits the illness script. The house staff were really good here. There were no signs of pneumonia other than an abnormal chest x-ray. There was no fever, no productive cough, no rigors, no upper respiratory tract symptoms. And so they said, that doesn't sound like pneumonia, because I had actually beat into their head, let's be sure it really is pneumonia. If it doesn't match, start over again. Go back and retake the history, do the physical exam, just like we did in the old days, the good old days. Weren't that good, but yeah. So let's talk about the dual process theory of cognition. When we make diagnoses, and it's really diagnostic decisions, we start with system 1. If that doesn't work, we go to system 2. Well, how many people think they know what system 1 and system 2 are? Good, we have somebody who knows. You'll all know and you'll all recognize that you actually use system 1 and system 2, you just don't know the names. So system 1 is experiential, and the best example of system 1 is rheumatologists, and you'll see why. It's intuitive, tacit, pattern recognition. Someone comes in with low-grade fever and swelling of the MCP and PIP joints, and it's a 28-year-old woman, and you feel the joints, and they're spongy and tender. It's probably going to be rheumatoid arthritis, and now you check to confirm that it's rheumatoid arthritis. That's pattern recognition. You know what rheumatoid arthritis looks like, so you go through it. And you match that against your illness script, because that's the illness script for rheumatoid arthritis. System 2 is analysis. It's a careful analysis. It's very deliberate. It's rational. It's careful, and it's wide differential. It's the cases that as an internist I get really excited about, when it's not obvious what it is, and I have to think through the broad differential and consider, is there something I'm missing? They're not independent. We go between system 1 and system 2 all the time. Sometimes we want to do system 1, but we're missing a piece of information. We go to system 2 and says, what information would we need? We grab that, and then we go back to system 1 after we have more information. In the patient that we just presented, the house staff were concerned that the patient could have heart failure, so they got an echocardiogram. Once the echocardiogram comes back, the whole story makes sense. It didn't make great sense before then, because he really didn't complain about orthopnea and PND, which sort of surprised us. Let's reconsider the first patient. System 1 was the patient had type 2 diabetes. Why? Because they said he had type 2 diabetes, and most 55-year-olds who come with an elevated blood sugar to the hospital have type 2 diabetes. So it's perfectly fine to say he has type 2 diabetes. System 2 was we needed a broader differential, and we invoked it because system 2 because system 1 did not feel right. This was not the intuitive vanilla type 2 diabetes that we see all the time. There was something that was bothering us. His BMI was 13. So this is a patient I saw in 1976 when I was a second-year resident. A lot of the information that you might want in this patient was not available because we didn't have those tests back then. We could not get a PTHRP. It's a 50-year-old male veteran who presented with chest pain. He was sent for a stress test by the intern, but the lab could not do it because he was tachycardic. His labs included a calcium of 11.5. I remember this guy. I'll never forget this guy as long as I live. I don't know if any of you worked in a VA with 20-bed wards. So you used to stand in the middle of the ward and you'd make rounds like this. And so we're making rounds and we're pointing it out, and all the patients are helping you. How's Mr. Jones doing? He didn't sleep well last night. There was no HIPAA. So the intern was on the night before I was not on because we had dysynchronous admissions, and he points to the bed and said, "Oh, that guy's it's nothing. He's a postal worker. He has vague chest pain. I'm just getting a stress test to make sure he's okay." So he comes back, and I said, why is he tachycardic? Well, it's because he's volume contracted because he has 5 liters of daily ileostomy losses. He'd had a previous colectomy for Crohn's colitis. I said, maybe you ought to tell me the story. This was not the sharpest intern I ever worked with. And I was a brand new second-year resident, so I doubt that I was that sharp myself. But I knew there was something wrong. So first of all, how many people know what normal ileal output is? I ask this question a lot. I can find very few people who know what normal ileal output is. And nobody's answering. So you can say it? What? 1.5 You're wrong. That was direct feedback. Okay, let me tell you how you're going to remember it. Some of you may remember what normal stool output is, and a normal amount of stool per day. You probably don't, because this is really, unless you're a gastroenterologist, you really don't care about poop that much. All you care about is, are they pooping or are they not pooping? 50 grams per day is normal stool output. Remember that, and that's 50 cc's. Remember that the colon reabsorbs 90% of the water. You learned that in physiology. You just remembered that you learned it in physiology because you hadn't thought of that in the last 30 or 40 years. So it's a half a liter. If it's an end ileostomy, just because you see a lot of loop ileostomies now, how many people know the difference between a loop ileostomy and an end ileostomy? I'm going to teach you something. And only because I had 2 patients in whom this was really important. So a loop ileostomy is something that's a diverting ileostomy in people who are being treated for colon cancer, especially in the sigmoid area. And the idea is to put it at rest while you do radiation and chemotherapy before you do the debulking procedure. And what they do is they go in laparoscopically and they pull out a piece of ileum and do a temporary ileostomy. And they don't always get close to the terminal ileum. And I had several patients who had 2 to 3 liters per day because it was too proximal. And I had one patient who had to be on home IV therapy throughout his chemotherapy and his radiation therapy because he had such large output from his ileostomy. An end ileostomy is actually a very careful procedure where they create a pouch and it's supposed to be permanent. Anyway, this guy had that, and he's now putting out 5 liters per day, and he tells us that it's been going on for about 4 to 6 weeks. With repeated testing, he consistently had an elevated calcium. So his problem representation is a 50-year-old man with chest pain, tachycardia, markedly increased ileal output from his ileostomy, and an elevated calcium level. So that was 1976. 41 years later, I've never seen this problem representation again. And I presented this case to hundreds and hundreds of people, probably thousands of people. I presented it in grand rounds over 10 times, and I have yet to find somebody who saw a patient with this problem representation. You cannot use System 1 to diagnose this case because you don't have any experience with a 50-year-old man with chest pain, tachycardia, and elevated calcium and increased ileostomy losses. Some people do figure out the case. And now let's talk about how you would do it. And I will admit, as a second-year resident, I did not figure it out. We ordered every test we knew, and something came back abnormal, which is also a strategy. Because we knew it was System 2, and so we went through the whole differential. We actually listed the differential and ordered everything we could to try to go through the differential. System 1 thinking, so what happens is I use this as a teaching case all the time with students and residents. And so I say, write down what you think is wrong. And what they usually do is they focus on the hypercalcemia and say, okay, it's either cancer or hyperparathyroidism. Some of them get really fancy and say, well, Crohn's, maybe that's like sarcoid, so we'll blame it on sarcoid. That he had both Crohn's and sarcoid. He had a normal chest x-ray, by the way. They don't develop a problem representation, and they don't try to explain all the findings. They just attach themselves to one abnormal lab value. This is an obtuse diagnosis. The only way to get there is to actually list either writing them down or in your mind, all the different causes of hypercalcemia. And you probably need to look them up because this is not one of the most common causes. I have seen this thing cause hypercalcemia more than once, but never when someone who had an ileostomy. If you go through the differential diagnosis, the correct answer, which is hyperthyroidism, becomes a consideration. And about 15 to 20% of students and residents get it right if they think about it very carefully. Remember that hyperthyroidism does cause hyperdefecation and it decreases the transit time, so you get more fluid going to the ileum and we don't have the colon to reabsorb the water. So instead of hyperdefecation, he got frank diarrhea. I didn't figure that out in 1976. In retrospect, I probably still wouldn't figure it out. Few learners include hyperthyroidism in their initial differential, and a few more do it at the end, who are really good at diagnostics and trying to figure out what could possibly cause diarrhea and hypercalcemia. In this case, in order to get there, you need system 2, even though we sort of took the easy way out and ordered everything. In some ways, that was different system 2 because we went through the entire differential and said, this is really unclear. We got to figure out what's going on. Most diagnostic decisions you make every single day are system 1. We only move to system 2 when we must. Somebody comes in with hypertension and they're on an ACE inhibitor and their blood pressure had been 150 over 100 and now is 145 over 95. They're probably taking their medicines. We need to add something else because our experience is that if we add a diuretic to an ACE inhibitor, we're more likely to get good blood pressure control. That's a decision, a treatment decision, but that's system 1. We don't have to go through a real careful analysis. We move to system 2 when we must. As you gain expertise, you can do more with system 1 than with system 2. So if I presented to a third-year medical student this woman who comes in at 29 in clinic complaining that her hands are hurting and she has abnormal findings in the MCP and PIP joints, first of all, they might not even know how to examine the hands, so they couldn't get that information, whereas a rheumatologist would immediately be thinking rheumatoid arthritis, quickly check the joints and say, yeah, we're pretty sure we know what's going on. The medical student's going to get there eventually, but they're going to have to spend more time and think more broadly about what could be going on. So system 1 for experts, what happens when you have expertise is your illness scripts have greater granularity. So there's more things you're looking for to make sure they fit, and there's more red flags, more things that make you worried. So, for example, I happen to have this passion for sore throats. And there are red flags in sore throats that make you think it's much more serious disease. One of my favorite diseases to write about and think about right now is Lemierre syndrome. It's a very complex syndrome, and people with sore throats get better whether I give them antibiotics or not. And if they're getting worse, there's a whole new differential diagnosis that very few people even have thought of. I've thought of it obsessively. And therefore, I know when to go to system 2. So my other big hobby besides sore throats is acid-base and electrolyte disorders. And at the VA, for the last 20 years, once a month, they've presented me acid-base and electrolyte disorders. So I've had almost every acid-base and electrolyte disorder presented to me more than once. The chief residents try to stump me. After 20 years, they rarely stump me. I saw these numbers and I thought I knew the answer. How many people think they know the answer just from seeing those numbers? How many people see those numbers and it's like they all blur together and say, damn, it's a lot of numbers? This is a 41-year-old woman who's referred to a nephrologist and is presented to me at Morning Report because of CKD and acidosis. The nephrologist is a very good nephrologist. He saw the numbers and he was pretty sure he knew the diagnosis, and then he confirmed it. She takes NSAIDs over the counter for arthritis, has not seen anybody for the arthritis. She drinks 4 liters of Coca-Cola a day. and she's on 20 milliequivalents of potassium chloride daily. How many people think they know what the answer is? And that is usual. Nobody will raise their hand. Even if you think you know the answer, you're not going to raise your hand because you don't want to embarrass yourself. But this is not most people's expertise. You get to ask me, there's 2 questions that'll lead you to the right diagnosis. So does anybody want to ask me a question?
Yeah, what are those numbers referred to?
What?
What are those numbers referred to?
Oh, what do the numbers refer to? Okay. I guess this is new school. Sodium is 141, potassium is 2.8, chloride is 115, bicarb is 14, BUN is 32, creatinine is 2.0, and glucose is 98. Anybody have any questions? She does not have hypertension. Great question. Except for that would probably be a metabolic alkalosis, wouldn't it? Not an acidosis. So the question I asked is, why does she drink 4 liters of Coca-Cola a day? The other question I could ask was, what is the urine pH? So system 1 thinking, this patient makes sense to me and only needs 1 or 2 additional pieces of information. If you're not an expert at acid base and renal problems, which I find that most people shun like the plague, there's no obvious answer, and they'd have to develop a careful differential diagnosis, or better yet, get a renal consult. It takes a lot of time and requires more tests because the pattern is not one that you've seen before. The only reason that I knew it is I've seen this pattern because I study this stuff. And so this is my hobby. She drank 4 liters a day because her mouth was always dry. Okay, now how many people think they know the answer? You're still not going to raise your hand? We got 1 who raised. We got 2 raised hands. Okay. Okay. The urine anion gap was positive, which means it's a renal acidosis. And the urine pH was greater than 6. How many people know what the most common cause of distal RTA is when an adult develops distal RTA? This could be on a test if there are any residents in here. This could be on your boards. This is Sjogren's syndrome with distal RDA. So she was drinking 4 liters of Coca-Cola because her mouth was always dry because she has Sjogren's, and Sjogren's causes renal dysfunction and causes distal RTA. Many rheumatologists know that, many nephrologists know that, and almost nobody else knows that. This is not a common problem. You may never have seen it before. Maybe somebody will make this diagnosis once because they heard it today, but you'll probably forget it. So let's talk about the challenges, heuristics and biases. Kahneman and Tversky, they had a skeptical attitude towards expertise and expert judgment. And they did studies of experts, they did studies of college students, and they'd give them problems to solve, and they'd try to trick them, and they'd show they could trick them. They focused on why people make errors. They focused on the shortcuts or rules of thumbs, which they call heuristics. And heuristics often help us, but they have risks. Here's some of the common ones. The anchoring heuristic, focusing on one piece of information. For example, this patient has type 2 diabetes, or they have hypercalcemia, and so therefore they probably have cancer. The availability heuristic, the last patient you saw, a particularly memorable patient. When I was an intern in the ICU, I had 2 patients who had toxic epidermic necrolysis from allopurinol. That was given because they had an elevated uric acid, they did not have gout, which asymptomatic hyperuricemia used to be treated with allopurinol in the 70s. I recently read an article from Taiwan where they once again showed that treating asymptomatic hyperuricemia gave you a risk of TEN. I don't know why they did this study, why this was still being done in the last 3 years, but it is. I've been scared to death of allopurinol and have very strict indications in my mind for using allopurinol my entire career, even though I know the risk is very low. It's something like 1 in 1,000 or 1 in 10,000, but it doesn't matter. I saw these people die. And you all have stories like that where you remember particular patients, or you always look for a certain thing because you found it once and you saved a patient's life, so you're not going to stop looking for that. Premature closure, that's related to the anchoring heuristic, and I'll show you a slide about premature closure. And framing bias. The framing bias was perfect in our first patient, right? People react to particular choice in different ways depending upon how it's presented. Once I told you that he didn't take his insulin as prescribed and he was cocaine positive, he said, oh yeah, I know that guy, he's just not taking care of himself, it's not a big deal. And my resident, who was a little bit snarky, did call up the ICU residents and told them what we'd found out, and I think he was just bragging a little bit. How many people have seen BBC Sherlock series? Yeah, so you always get good responses to this at Grand Rounds because we all went into medicine because we wanted to be Sherlock Holmes. At least I did. He's in a room and a rookie detective is standing there pontificating about the crime. He solved the crime. He says, this is what happened. And Sherlock says something like, well, what about this painting over here? And what about the blood splatter over here? And the guy keeps on blowing him off as if Sherlock is an idiot. And so Sherlock says in his snarky voice, and Benedict Cumberbatch is just brilliant in this series, you have a solution that you like, but you're choosing to ignore anything you see that doesn't comply with it. We've all made that mistake. I've made that mistake multiple times, and I promise you every one of you have made that mistake. That's our risk, is explaining away a finding that we're not comfortable with. So let me give a different construct. Gary Klein, his book is called Sources of Power. Gary Klein started the naturalistic decision-making movement. As opposed to Kahneman Tversky, who did paper studies, he studied actual people making actual decisions. So rather than doing it in a lab, he did it in real life. He started out by, he asked the question of how do experts get it right, especially high stakes, uncertainty, and time pressure. Does it sound like any job y'all have ever had? And he studied firefighters to start out with. He did a lot of other studies afterwards. And what he did is he asked firefighters, how do you make decisions? And the firefighters said, we don't make decisions. We just fight fires. And then he went out in the field and watched them, and they're making decisions all the time. Do you go in the front door or do you go in the roof? Do you use foam or do you use water? And do you chop down the front door? There's all kinds of interesting decisions they make. And so he would record what decisions they made, and then he'd ask them afterwards, how did you make that decision? And from that and from other studies, he developed something called the recognition prime decision-making model. It's very similar to System 1 and System 2. It has one or two slight different features, and I think this is the road to expertise. Approach 1 is to use pattern recognition to match the problem representation with an illness script, exactly what we've been talking about so far this morning. Experts notice red flags or discomforts when one or more key features don't match. And experts have more completely developed illness scripts. An expert firefighter will notice the color of the smoke will change what he or she does. Approach 2 is related to hypothesis testing. It's a search for missing data. For example, to question our patient about previous pancreatitis, because once that was in our differential, we had to go and get that piece of information. Once we had that in steatorrhea, it redefined what was going on. We went back to approach 1 and we knew what was going on. It's more System 2, but then reverts to System 1 when data are collected. And System 3 is the most important thing in my mind. It's the pre-mortem exam. It's very popular in business now. It's to mentally simulate the consequences of adopting the diagnosis. Mental simulation can highlight concerns and sometimes leads to reevaluation. And it's what I was taught as a medical student, what can you not afford to miss? 75-year-old patient comes with severe abdominal pain. Nothing is abnormal so far. I always get a lactic acid, even if there's a normal anion gap, because the lactic acid goes up before the anion gap because I'm looking for infarcted bowel. Because if I miss infarcted bowel, they're dead. If I diagnose it, we might be able to save them. So 75-year-old patient comes with severe abdominal pain. I mentally simulate what would be the cost of missing this and how can I try to find it and convince the surgeon that it's really there. So in an original patient, we started with approach 1. We rejected it because we were uncomfortable accepting that diagnosis. We got further history stimulated by our discomfort and used approach 3, knowing the diagnosis would help us prevent hypoglycemia and possibly help with steatorrhea and really change how we thought about treating his diabetes. We're no longer worried about his hemoglobin A1C. We're worried about not causing hypoglycemia, but also not causing hyperglycemia. So this is a case in which I think we use the recognition prime decision model. It's an 82-year-old woman who's admitted to the ICU with an upper GI bleed. Her endoscopy showed an esophageal ulcer, which was coagulated. She was transfused and volume repleted. This was on Thursday. She's in the ICU all weekend. We only take unit transfers on Mondays, so Monday morning she's transferred to our team at 7 a.m. We're starting rounds at 7:45. The intern quickly looks in the room and says, "She looks stable." Really didn't have time to examine her. So just to remind our questioner from before, the sodium and potassium are normal. This is original when she was admitted. The chloride and the bicarb normal. She has a high BUN, high creatinine, which you expect with a GI bleed. She gets IV fluids, and Monday morning she has a little bit low potassium. She has a low bicarbonate. Her BUN and creatinine have corrected. Her glucose is fine because she's no longer as much stress. And this is a normal gap. For those of you who are not good at math in your head, that's a gap of 13. And I asked the question, why is her bicarb 17? And the team looks at me like I'm an alien. And I might be. So, approach one, calculate a normal gap, assume metabolic acidosis. Usually a normal gap is metabolic acidosis. And we must switch to approach two to seek additional information. Why would this lady have developed a normal gap acidosis? Could it be bicarbonate loss? She had no history of diarrhea, and she was not on acetazolamide. Those are only two reasons I know that she would have that. She didn't just develop a proximal RTA. She was not given any other medications that would cause it. Could it be a renal acidosis? Well, she has normal renal function, so it's probably not a renal acidosis. It appeared quickly, so a distal RTA is very unlikely. That would appear over time. Could it be dilution acidosis? Everybody talks about dilution acidosis. ICU docs like to talk about dilution acidosis. If you look at the literature, the bicarb really doesn't go down to 17 with dilution acidosis. It might, and I've had ICU docs argue with me about this case that, well, it really will, but I can prove that I was right. If it's not a metabolic acidosis, could it be a respiratory alkalosis? And how many people thought of respiratory alkalosis when I first put those numbers up? Approach three, we don't want to miss a hypoxic cause for respiratory alkalosis. Maybe she just had a PE. Therefore, we need a blood gas and further clinical investigation because I can't afford to miss a respiratory alkalosis caused by hypoxemia. So we go to the bedside and we order labs. I look at the chart and she gained 12 pounds since admission. Now this is July of 2 years ago. Have a brand new intern and a resident who transferred from another program, and it was her first rotation, and I don't think the other program was quite as good as ours. The patient had new small bilateral pleural effusions. We ordered a pro-BNP and found out that since the time of admission, the patient had been getting 200 cc's of normal saline per hour. Our ICU attending was not a micromanager. He should be. We stopped the IV fluids. We gave 1 dose of furosemide. When we went to the bedside and the patient had RALs and the patient was using accessory muscles, was on 3 liters and had no history of any lung problems or heart problems. Her blood gas shows a respiratory alkalosis. On 3 liters, she still only has an O2 of 79. She has a PCO2 of 29 with a bicarb of 19. Her pro-BNP is 4,000. We give her 1 dose of furosemide, stop the IV fluids. She lost 8 pounds and lost her nasal oxygen. Went home that day. The insurance company was happy because we didn't have a prolonged hospitalization. The house staff was happy because that was one less patient they had to see the next day. And the patient was happy because we actually treated her and reversed what was wrong. I had a very nice lunch with the intern and resident who'd been giving 200 cc's of normal saline and discussed fluid management with them, and they did not make that mistake again the rest of their residency. So let's talk about cognition and medical education, because this is a talk about medical education. Our learners want to know how and why we make decisions. Facts are retrievable. I've never met a resident or student who didn't have one of these in their pocket. And they know how to use them, and they know how to use them better than you do. They can look up facts all day, but they don't know how to use the facts because they don't have the experience. So it's our job to explain why we're doing what we're doing, to teach what the diagnostic reasoning is every single day. And it's because wisdom trumps knowledge. It's great to be able to list all the things for hypercalcemia, but it's another thing to be able to use them and understand how to do it in practice. What should we be teaching? Because if we're experts, we have more refined illness scripts and problem representation, we need to help our learners know when System 1 is adequate and when they need to go to System 2. If they progress, we should spend more time in System 1. They get there faster if we help them understand what the clues and cues are. I hope I did in some of these cases today. What should students and residents do? They need to do deliberate practice. They need to know what happens to the patient. If they leave the service, they need to go back and find out what happened to that patient. I had a case presented to me at another hospital last week, and it was up in the air, and I emailed them yesterday to find out what happened to the patient. I had to know, because otherwise, how am I going to be able to evaluate the next patient who has that same problem? And I do that all the time. I can't not know. Attending morning reports, think carefully anytime. Hopefully while I was presenting these cases, you were trying to solve them along with me. And that process and reading cases helps you get better at diagnosis. And reinforce what you learn about complex patients with focused reading. I do that to this day. I had a patient who had staph lugdunensis bacteremia. How many people have ever seen staph lugdunensis bacteremia? Well, staph lugdunensis is a coag-negative staph that acts just like Staph aureus. And I didn't know anything about it, so I read a lot about it, and I've seen about 5 more cases since then. Because I know to look for it. I learned from that one patient. Michael Lewis wrote a wonderful book about Kahneman Tversky that just came out called The Undoing Project. You probably know Michael Lewis. He wrote Blindside, The Big Short, Moneyball. And this tells the story of how Kahneman Tversky started the whole field of cognitive psychology. I'm more than happy to share my slides. Feel free to email me and I'll send you the slides sometime tomorrow because I'm going to be traveling the rest of the day. And I thank you so much for your attention and the opportunity to give this talk. I guess we could have 1 or 2 questions if anybody is not in a rush to get to their office or golf tee time. I'll be more than glad to. Yes.
Well, I independently learned never to trust the diagnosis of pneumonia from emergency enough.
Right.
Is it sufficient? I was interested that you said in the 70s people would just be admitted for their symptoms.
Right.
So is it sufficient for emergency physicians simply to admit this person's sick?
They can't.
Can you repeat the question?
So the question is, why not let the emergency department just say, they're really sick, I know they need to be admitted, but not put a label on them. And they do that in some other countries. But my understanding, and I could ask Gluckman, he could probably tell me better than I know, I think you have to have a label to get admitted in 2017. Well, in 1975 when I was an intern, you didn't need an admitting diagnosis. You could have a diagnosis of fever or a diagnosis of dyspnea. You could have a symptom as your diagnosis, and they won't let you admit without that. Many people in the diagnostic error field think that's a major problem because once you get that label, you might shut down thinking.
How can we change that then?
I don't know that we can change that. What we can do is we can teach everybody just to start over and not. You just can't trust the admission diagnosis. And there's good documentation from the emergency department literature of about 30 to 40% of community-acquired pneumonia admissions don't have that. That's my favorite one is community-acquired pneumonia. They miss that all the time. but there are plenty of others that they miss. Cellulitis, so bilateral cellulitis probably doesn't exist, but people get admitted for bilateral cellulitis. And so it's our, those of us who teach, it's our job to make the residents just as skeptical as we are. So I think it's 9 o'clock. I'll be more than glad if anybody wants to come up and chat, and I appreciate your attention.
You've done bird watching.
No, I